Thank you so much, Pierre, for a fantastic talk, a really excellent overview of the subcutaneous ICD, and to Haran as well for his excellent talk. I've got, I mean, it stimulated a lot of questions in my mind. Angelo, do you want to kick off the discussion, or shall I start?
I can certainly do. Again, congratulations, Pierre, for this also, I would say, partially quite provocative argument for and also in favor of the subcutaneous SICD. So my point is pretty simple. So let me put you in a clinical situation. So do you make any difference if you have in front of you a young patients and old patients, primary prevention, secondary prevention, to choose the SICD, or you have totally abandoned the transvenous one? So
yeah, sure. So I think essentially, obviously, the question of what is young and what is old is becoming a rather political question. But essentially, if you have a patient, let's say cutoff age 65 to 70, who doesn't have any risk factors for infections such as diabetes or renal impairment, renal failure, then I think it is reasonable to put it in the venous system, because this is a group of patients more likely to progress to conduction disease. Most of the patients I'm weighing up quite carefully now. If I can avoid a transvenous system, then I will, particularly because this risk of lead complications over about a 10 to 15 year period. So I tend to veer much more towards a subcutaneous system, unless there's a clear indication for pacing or a contraindication because of infection risk.
Very briefly, Anna, you showed this beautiful data by Boston Scientific about the lead longevity. And these apply nowadays to Boston, but I'm suspecting that is also true for other manufacturing. So in general, the standard transvenous lead technology has been really outperforming our expectation. And certainly we learned a lot from Sprint Fidelis, from many issues. Now, the question for you is the same that I made or I put to Pierre. So are you considering anyone for the SICD again, if you take primary, secondary prevention, age, and other things? So it is anyone that you would say, this is my ideal candidate for an SICD, and this is one for transvenous?
Yes, indeed, Angelo. I think it's good therapy. It's very useful to have this option in selected populations. Indeed, young patients in whom you want to spare the venous system. So I would really, for me, the SICD is indeed preferred therapy in young patients, and especially patients who will not have rhythms which would benefit from ATP. Okay, so say idiopathic VF in young patients, I think is an excellent choice to be able to propose the SICD. For other patients who have more substrate-based, more arrhythmic substrates with VTs that can be treated by ATP, less young patients, I think I would really favor the transvenous ICD. So I really am today, in fact, implanting in the majority of patients transvenous ICDs. I think there are many shortcomings with SICDs. It's a therapy which is getting better. At the current generation, we definitely have less inappropriate shocks than what was initially the case, but I think there's still a lot of room for improvement. I mean, what Pierre failed or did not want to tell you was that there is no monitoring zone in this device. I mean, how is it possible today to have a third generation device in which there's no monitoring zone? If you want to know if the patient has had any arrhythmias, you need to implant an implantable loop recorder. It'll only show you stored episodes if the capacitor has charged. For non-sustained arrhythmias, it just won't record them. I think that's a serious shortcoming. at follow-up to know about the integrity, it doesn't give you any impedance values. It has this funny little scroll which tells you that everything is okay, but there's no value. There's no value for the sensing threshold. And I think for an ICD, it's important to know what the R wave is sensed at. And it doesn't, if you want to know, you need to print out the strip and use a little ruler to look at and to measure the R wave. And you know, of course, I think the smart pass has really reduced the risk of inappropriate shocks due to T-wave oversensing. But there are also other reasons for inappropriate shocks, such as myopotential oversensing, which won't be helped with smart pass, or rapidly conducted AFib. And if you do run into those troubles, there's very little you can do about it other than change maybe the vector, and that's just about it. So it's a bit of a black box. So, you know, I think one really has to take all these shortcomings into mind when prescribing this therapy. But on the other hand, it's definitely getting better, and the next generation is going to solve part of these issues. So that's actually what I tell my patients, that right now it's perhaps it's good therapy, but it's going to get even better in the future.
Can I ask a question about beta blockers? And this is a question that often comes up when I talk to colleagues about what device is going to go in, and it's appropriate for both of you actually. Sick patients, sick hearts, they all need beta blockers. So I guess the question is to Haran is, do you implant an atrial lead? So it's slightly off-piece dual chamber versus single chamber in those patients, because I know many people who still revert to saying these patients all need an atrial lead, they're going to go slow and we want AV synchrony. And to Pierre, I know you presented some data on this already, but we're going to give them beta blockers. They've got a sick heart. They might need pacing. And actually, there may be a need for a system. So a sub-Q may not be appropriate. Just be interested on your views, because they all need beta blockers.
Sure. I mean, I can come back first. I mean, there is data looking at programming pacing with patients on beta blockers. And of course, if you program the pacemaker pace at 70 beats per minute, they will be paced. But if you have backup pacing less than 40 or 45 or less, then the percentage of patients requiring pacing, or such as atrial pacing, is in single figures. And I think, you know, there is this over concern about putting leads in for beta blockade. And obviously, if the patient's got conduction disease, that's a different story. I mean, we've gone through a whole phase of giving patients with HOCM beta blockers and putting an atrial lead in. And then what usually just happens is you get atrial lead fractures, and they don't really need the pacing anyway. So I think if there isn't conduction disease, there isn't strong evidence to justify using a beta blocker. Haran's point about non-sustained VT, and you know, you want to know when the patient's getting non-sustained VT because you may want to do something about it. Well, if it doesn't translate into significant increased burden of therapy for the patient, or it doesn't translate into an increased mortality that you're actually going to do something about, then I'm not sure you need to know about all the non-sustained VT episodes. If the device does start to charge for non-sustained episodes, then you are going to detect those. There isn't really, you know, we know from Made It Writ, all these non-sustained episodes, if you start treating them, then you end up with more complications. So the key is to have the patients, the evidence we have really is you need the patients on maximum medical therapy in terms of their heart failure, beta blockade, ACE inhibitors. These are the things that are going to translate into a mortality benefit from the patient, rather than monitoring how many episodes of non-sustained VT they have. So I'm not so convinced that knowing about every run of non-sustained VT actually makes any difference unless it translates into a therapy for the patient.
I'll just carry on from here. I think I agree. The non-sustained VT is perhaps not that important, but nevertheless, I think a monitoring zone is. And these patients may have VTs which are slower than the rate you've programmed it. And we know from all the data that you also yourself showed, we tend to program therapy zones at higher rates as well to avoid running into inappropriate therapy due to rapidly conducted SVT. But we still like to have a monitoring zone. I think all of us do with transvenous ICDs program a monitoring zone, but you don't have that option with a subcutaneous ICD today. And I think that's really a piece which is really missing. Coming back to the question of the atrial lead, I do implant atrial leads in many of these patients. because of what you alluded to, the requirement for atrial pacing. They may have chronotropic insufficiency, and you're improving their quality of life by placing an atrial lead, allowing them to be more active, to exercise, and so forth. Furthermore, it's just so much easier following up patients who have a dual chamber ICD and knowing what's going on in the atrium, rather than having to guess, is this SVT, is this VT, the morphology is just borderline. So it makes the follow-up so much easier. But there are, of course, downsides to placing an atrial lead, of course.
I think we should also be quite conscious about the potential of upgrades in some of these patients. I'm sure that, Pierre has really has a very large experience with SICD. And now the question to you is, Pierre, so how frequently comes that you have to consider an upgrade either for CRT or conduction system pacing? So is this really an issue for you, or you don't see that one so frequently coming in your population?
Angelo, the main reason we don't see it a lot is because we're tending to implant in younger patients that don't have evidence of significant conduction disease, such as bundle branch block or marked PR prolongation. So the conversion rate to pacing is quite low. In the patients that we have had to upgrade, for CRT, for example, you have to be very careful with LV pacing because you end up with right bundle branch with quite unusual morphologies depending on the placement of the LV lead, and you can end up with right bundle branch block morphology, and that can really confuse the ICD. So if you keep the SICD in and do CRT, you've got to be really careful. And in those patients, usually we just convert over to a transvenous system fully. But conversion rate is low because we're looking at a very focused population in the majority.
Can I ask Pierre, just with respect to the SICD, we've obviously seen a real reduction in the size, the volume of the transvenous ICD from the kind of 150 mils decades ago to the kind of 30 mils or 30 cc's that it is currently. Clearly, the footprint of the SICD is bigger because of the way that the technology works, and my understanding is that that's probably not going to change. I'm just interested in, from your experience, the footprint of the device and showing that to patients, particularly the younger patients that you alluded to. Does that, how does that make them feel? Because I know from talking to some patients that some people do look at it and think, no, that's not for me. I'm just interested in kind of what proportion say to you, no, I don't fancy that, I'll have the transvenous, please.
It's surprisingly few. And I think what I usually do is I get their mobile phone out and I say, okay, let's look at your mobile phone. This is about 2/3 the size of your Apple phone. And then I said, do you notice it in your pocket? And they say, no. So and then because we're putting it submuscularly, unless they're very thin, then it can do cosmetically. But the majority of patients, it's not really. They look at it and think it's quite large, but actually, when you compare it to a mobile phone, it's not dramatically different. And then when they realise that it's going submuscularly and they're reasonably well built, it tends to minimize the problem. In fact, what I do now, I take the subcutaneous ICD generator and put their phone in their other hand, and they say, right, does the weight feel any different? It usually weighs the same. You notice the phone in your pocket? No. Okay, that's what the device will feel like.
Yeah, you've learned really to convince your patients. But actually, I would agree with you that I think overall, even though it does look bulky as it is, once it's implanted, it's actually quite comfortable. It's not so much of an issue. And I mean, the transvenous ICDs don't look that good either, do they? I mean, they're also quite visible. Sometimes they sort of bulge out. So, you know, aesthetically, I think you can't really say that the transvenous are any better. But I think that the company is working on finding ways of reducing the size in the future.
Yeah, that's right. They're trying to make them slimmer. I think they have to maintain the area for the shock impedances, but it's to do with, as you know, with the battery and the capacitor size. That's what needs to be slimmed down, and that's the challenge which they're working on.
And perhaps if the defibrillator thresholds can be brought down a bit by increasing the surface area of the lead and reducing the impedance, then you won't need so many joules, and that will of course reduce the battery size. So again, I think that this is a moving target. It's getting better, but there's a lot of room for improvement. I also think that we have less of a history with SICDs, of course. I mean, we don't have that much of a track record. We have some data which is somewhat worrying. You know, definitely this series from Germany where 20% of the patients who had a box change were not able to be defibrillated with the current setting. Yeah, it's like 20%, but it hasn't been reproduced by other centers. But it is worrying. What worries me also a little bit regarding this is the amount of how the R waves will evolve in the long term, because we know that the DFT may increase because of the fibrous tissue encapsulating the lead, increasing the thresholds. But how is this going to affect the R waves? We don't know that today because the device doesn't tell us what the R wave amplitude is. And I have had a couple of patients who've had inappropriate shocks due to low amplitude signals over follow-up and with a risk of detecting my potentials. So I think we need more data on this in the long term. So we'll have to see how this plays out.
The key thing, just 2 points, as you alluded to already, with the IDFT, we looking at the effortless data, that hasn't been an issue. I think a lot of it's to do with the implantation technique. The other thing is with a small R wave. I think you're right. You have to monitor your patients. Probably the best way is just to look at your patient's ECG and see if it evolves over time. Because if there's evidence that the R waves are shrinking or they're developing right bundle branch plot, that's a warning sign to look at the vectors again and to reevaluate the patient. I agree with you there. And cardiomyopathies, obviously, you can get progression in the ECG over time, but we've not seen that in significant numbers. I mean, even in our center, with over 400 patients implanted, we've only had to change out one device for loss of R wave amplitude as a result of progression of their cardiomyopathy. So I don't recognize it as a concern, but we haven't seen a significant number of issues.
The infiltrative cardiomyopathy, so young patients with sarcoid, amyloid, or a non-ischemic cardiomyopathy with a lot of scar, a lot of late GAD on their MRI. Pierre, you suggested you would you see whether these patients have advanced AV conduction at index presentation and then decide. I guess for a lot of these patients, particularly the younger ones, they may present and not have conduction abnormalities, but they may develop those in the future. And I just wonder how you evaluate and decide, are they going to get a subcutaneous ICD or not, or whether you go for transvenous in them.
Well, then you have to follow the natural pathophysiology of the disease. So if you're looking at sarcoid or amyloidosis, there is going to be progressive conduction disease, even though you may not necessarily see it at the beginning on the ECG. So I would have a low threshold to put a transvenous system in that situation. Or if we see a lot of GAD in the mid-myocardial septum, for example, in a patient with HOCM, we'll have a lower threshold to put in a transvenous device there, because there's fibrosis in the myocardium that you can see and may well progress to promotion disturbances. So I accept that. Yeah.
If I may have probably the last question to both of our speakers. We talked very little about complication of the ICDs or current complication of ICD, transvenous ICD. I'm talking about infection and eventually skin erosion. Is something that you have seen less frequently over the last years, or it is still the same proportion that you have had in the past years? And this is for both Haran and Pierre.
You're talking about transvenous ICDs?
Yes, transvenous ICD, yes.
Indeed, I think, the implant technique is so important. And the sort of figures we see in the publications that Pierre and I have shown you, I don't get the feeling that this is the rate of complications that we have. I mean, I've stopped doing subclavian vein punctures since about over 15 years ago, where I really went for axillary vein puncture. So there's a lot fewer pneumothorax is very, very rare. Low rates of lead fracture as well. And so I think with a proper implantation technique, we can really make this a better therapy, and with a much lower rate of complications than what is sometimes reported.
Yeah, I mean, I agree. I mean, we've all learned over time we're much better than what the literature has published, you know, which is often historical data from about 10 years ago. I mean, our infection rate, we managed to cut it from about 1% at implantation down to 0.3% with a number of maneuvers over the past 5 to 10 years. With generator placement being submuscular, whether it's, you know, I'm talking about all ICDs, you know, when we put in a transvenous, we tend to put more subpectorally now. In the thinner patients, similarly for sub-Q, we put submuscularly. We've got much better at implanting these devices to minimize erosion and infection with experience. So I think, you know, we're being a bit harsh on both types of devices for complications, because the learning curves have changed how we actually implant, and that'll manifest over the next 5 to 10 years in terms of long-term outcomes.
Fantastic. I think we're probably about time. We could probably go on all evening, but it's probably unfair to do so to everyone. I think we could probably conclude that there's two really elegant systems that we have in the transvenous and subcutaneous ICD, and they're both evolving, both in terms of their technology and the materials, as Haran you alluded to. And there's clearly advantages and drawbacks to both. And I guess it's watch this space as to see what comes next. So I guess it remains for me just to thank both Haran and Pierre for their time and for giving such fantastic presentations, and to Angelo, our editor of Arrhythmia Academy, for hosting this. And we hope that those of you watching find it insightful and thought-provoking and useful for your clinical practice. So thank you very much.
Thank you.
Thank you.